Okay, welcome everybody to another edition of Talking Away the Taboo. I am thrilled tonight. We have a very special program bringing on three different people in the breast cancer, ovarian cancer, and fertility realm who are all here to tell us their stories, give us their professional expertise, and really bring comfort, support, and validation to all of you. And so we are an hour earlier than we expected, but we are here now, and this event will be recorded, assuming that everything goes well with the technology here. So you don't have to worry if you miss pieces of this. We know different people are in different times, and we are going to get started. So let me bring everybody on here. Three amazing people. So let me introduce all of them to you while everybody is coming on. So I have, there she is. Okay, we have two out of the three. We're getting there. Let me finish. Let me do the introductions. So we have Peggy Cottrell. Peggy, am I pronouncing your last name correctly? I just want to
Yes.
make sure I get that right.
Yes,
Cottrell or Cottrell?
Cottrell.
Okay, perfect. Peggy Cottrell, who is an MS and a CGC, a certified genetics counselor, I'm guessing, who is the genetics program manager at Sharsheret. She's a graduate of Sarah Lawrence in a master's of science in genetic counseling. She consults with women and families and answers individual questions about their family histories, their BRCA mutations and personal risks of hereditary breast and ovarian cancer, and contributes to the development and implementation of Sharsheret's hereditary cancer resources and programs. I see Sahar here. Dr. Wertheimer, she's a friend of mine, so I can call her Sahar, but we're going to call her Dr. Wertheimer all here. Then we have Rachel. Rachel is here. Hello, hello, hello. Rachel is here. Rachel actually is a dear friend of our social media manager, Karen. And so Rachel is here. Rachel is a registered dietitian nutritionist who specializes in oncology nutrition at Mount Sinai in New York. She tested positive for the BRCA1 gene mutation at the age of 21. And at 25, she started prophylactic screenings, breast MRIs, dermatology screenings, physical breast exams, birth control, and egg freezing as a way to take control of her future. And Rachel is going to share more of her story tonight. And then we have my friends, Dr. Sahar Wertheimer. She's a reproductive endocrinologist and infertility doctor in LA. She did med school and residency at Albert Einstein in New York, and her fellowship at Cedars-Sinai. And she's very passionate about women's health education and advocacy, especially in the Orthodox Jewish community. And she is also, are you now the president also of JOMA? Did we not discuss that?
I'm on the board. We don't do those positions anymore. We changed it.
Okay, excellent. But the thing that you need to know about Dr. Wertheimer is that she really pitched in. She was, let me just say that she was not a second choice. She was our second other number one choice to be here in place of Dr. Maslow. Dr. Maslow is on our time zone here in New York, which is why I initially chose her. And Dr. Wertheimer is in LA and is doing this towards the end of her day in the office. So I really appreciate you stepping in when Dr. Maslow was not feeling up to it.
My pleasure. We'll miss Batsheva.
We miss her, but we know that you are absolutely incredible, and thank you for being here. I think the right way to get us started tonight, and just to frame this discussion for everyone, is we're going to have Rachel tell her story. We're going to go into a bit of details with her, and then we're going to have Dr. Wertheimer and Peggy talk about the different pieces, the medical pieces and the genetics pieces, both in terms of treatment, in terms of advocacy, in terms of resources, and we'll have them add in. And we'll also at the end open for questions, and happy if anybody wants to put any questions also in the, hi Abby, any questions in the comments or send me any questions privately, please do so. We're happy to answer as much as we can for tonight. So Rachel, take it away. give us, I will jump in and ask you some questions, as you're discussing, as you're sharing with us, but, start from the beginning. When I guess I'll sort of open it up and say, when did you know that this was something that was in your family? And then how did you even know to get tested? Let's maybe start there.
Yeah. So I knew to start to get tested when my mom had told me and my siblings that she had tested positive for the BRCA mutation and that my grandmother had also tested positive for the BRCA1 mutation. When I'm the oldest of 4 kids, so when we were much younger, my mom did all of the prophylactic surgery without us even knowing. We stayed by my grandparents, and she had done everything for her. And then a couple years later, she ended up telling us. And right when I found out, I was like, okay, I want to get tested also, more as I want to take control of whatever I can in this situation. I actually did speak to Peggy on the phone. I don't know if you remember Peggy, but I spoke to Peggy right before I had gotten tested because my mom wanted me to speak to a genetic counselor and kind of learn what the repercussions are of getting tested, what it means if I do test positive. For me, the decision to get tested wasn't even like a big decision because it was more of, I know that I want to do this. And if I'm positive, then I'll get to take control of everything that I need to take control of. And if not, amazing. So I got tested in July of 2021, right before my 22nd birthday, and I got the results in August that I was BRCA1 positive. At that point, I had learned that there was nothing really I could do until I was 25. So it was kind of me just sitting with the information for a couple of years before I could really do anything, which was fine, and I didn't really think much about it, but I wanted to get the testing out of the way.
Can I stop you just
Yeah.
for a second, if you don't mind? Can you just go back and about your mom? You said when she had everything done in
Oh,
terms
yeah.
of,
Sorry.
can you explain? No,
Yeah.
please don't apologize. Just explain what that meant in terms of she took control of her situation and she had everything
Yeah.
done.
So my mom had already had 4 kids. So she did a double mastectomy, which was getting rid of all of like her breast tissue that may cause increased risk of breast cancer. So she did that. And then she also got a hysterectomy and an oophorectomy, getting her ovaries and uterus removed to take away almost all of the risk of ovarian and breast cancer. So that's kind of what I meant by that. So now her risk, I mean, the doctor can correct me if my numbers are wrong, but from like an 80 something percent chance to like a 0.9 or 2%, whatever it is, which is incredible. So I was like, okay, I'm going to get started on this early. And then this summer I turned 25 and I was making my appointments, getting ready. And then the day after my 25th birthday, I went in for my first MRI. So that was kind of my birthday party for myself.
I, and
Um,
and the so 2 questions now. Why did you have to wait until you were 25? What's the like magic, or is there some magic with the 25 number? And then why were you doing an MRI?
yeah. So I don't know why 25. I knew that was like the rule. The MRI versus mammogram was because when you're a younger woman, your breast tissue is denser. So a mammogram isn't as specific as a MRI, and an MRI is going to be able to test more specifically if there may be anything cancerous in the test. And what the nurse or the doctor had told me before I went in was that there is a chance of something coming back, but that doesn't necessarily mean that it's cancerous. So they gave me that warning, but that was a little bit of a scary realization to hear before I went into the MRI. Like thank God, like I've always been healthy. I've never had to go get any type of IV or any type of specific test. So going into this like MRI by myself, having to get contrast and all of this was like a whole new world for me. So I went in, they gave me headphones. The woman was so nice and was walking me through every step of the way, talking into the machine for me. I tried to like just take deep breaths and be calm because it's a little bit overwhelming to go into an MRI machine. But that was that. After the MRI, so I can go back. Let me take a step back a little bit because I got my results back, and then it's like, okay, what do you do? Who do you talk to? How do you coordinate your care? And for me, that was the most overwhelming part. So I had just moved to New York right before when I turned 25, and I was starting to work at Mount Sinai. So I had all this new insurance and trying to figure out that whole world as well. So I made an appointment with I don't know exactly what her name is like the oncology like coordinator. Her name is Dr. Stephanie Blank, and she was like my point person to who everybody else I would need to go to. So I would need to see a breast surgeon, I would need to see a regular OBGYN, I would need to see a dermatologist, who am I missing? A reproductive endocrinologist, and all these people. So I needed to make appointments with every single different doctor. So I was kind of trying to like check one off at a time. So the first was the MRI. So that was done. And thank God everything came back clear. And now I don't have to go for another year. And then in between that time, that's when I have to do the self breast exams so it's like 6 months. First you do the MRI, then you do 6 months later, you do the self breast exam, and then you do again an MRI, and you alternate every 6 months. And then once you hit 35 or 40, that's when you begin the mammogram. So I have some time, thank God. And then after that, it was brought to my attention that I would be able to freeze my eggs so that the embryo itself can be tested for the BRCA mutation, and whichever embryos are tested positive for that mutation, they can take it out or not implant it. And when I heard that, I was like, of course, that's something that I want to do because I want to get rid of this mutation and this risk for my children. I'm very single. I'm nowhere close to having kids anytime soon, but I knew that was a decision I was going to make for myself and for my future family. So I got connected with RMA, which is Reproductive Medical Associates, which is where Dr. was going to come. Dr. Maslow was going to talk to us. And so I had an initial consult with one of the reproductive endocrinologists, which was very overwhelming. And I had gotten a lot of information, and I learned a whole new vocabulary that I had never imagined that I would have to learn. That was already months ago at this point. And then I decided I needed to give myself like a little bit of time to follow all the information until I was really ready to do it. And then I decided at the end of December, January time that I was like finally ready to go through with it. And I just actually finished the first week of February doing my first cycle of egg freezing. The cycle itself, is there like anything that I should stop and explain, or am I okay?
No, you're good. I'm going to give you another like minute or two to kind of like talk a little bit about this, and then I think I'm going to pass the baton to the other two professionals, and then we'll circle back.
Okay. Yeah. So the egg freezing process was, it was definitely a lot of information, but I had the most incredible support system. A lot of them are actually on here watching. And they did everything from meeting me at the appointments, the appointments to like get my blood work and to do the vaginal ultrasounds, waiting for me at home at night when I needed to do my injections, sending me like funny things throughout the day. One of my friends got me like an egg cooker, like just like funny little things. And that was just, it really made the whole experience so like, it made it fun, to like lack of a better word, because I don't have a partner with me doing it, and I just really had a whole team really supporting me, which was so so special. But down to the nitty gritty, yeah, like parts of it really, really were hard. I had never given myself injections of any kind. The first night that I was giving myself, you have to give yourself 2 different kinds of injections. And also because of my BRCA mutation, I had to take a medication that was kind of like a chemo drug that kept my estrogen levels low because I was giving myself hormones that were increasing my estrogen levels that could put me at risk for like cancer. I don't know, the doctors can put that in correct terms, but anyways, the first night I just blacked out and really like stabbed myself. It was traumatizing for everybody in the room, but we got it down to a science and it was really good. And the first, like, I would say the first like 7 or 8 days, I felt really okay. Like I was going to work, I was exercising, my life was kind of going on as normal. Towards the end, I was exhausted. I was like getting home from work and I would take a 2-hour nap. I just felt like drained completely. And then the day of the extraction, I went with my mom, and I went in and it was really like 3 seconds. I don't even remember it. They put me to sleep and I woke up and I'm like, okay, it's done. And they told me how many eggs I got, and they told me it was a really great number and I was so excited about it. And the next couple of days afterwards, I felt like the 3 days after the extraction were definitely the hardest, the worst.
I think we lost her for a second. Let's give her a second to come back. You're there. You're there. Go
Sorry.
ahead. Go ahead. Okay.
You're paused. We're good? Okay. So the
We hear
3
you.
days after the extraction were definitely the hardest. Like I felt like this is how I explained it to everyone. It literally felt like somebody was standing on my bladder. Like it felt like I had to pee every 5 seconds. Like I was just uncomfortable. But then the next week I was like back and ready. I was skiing the next week. So it was a quick turnaround. But what I heard after, and then this is where I'll stop and kind of pass it over, is so I got a really good number of eggs, or so they told me. And what I think maybe I didn't really understand the number game of it all, because what they had said to me was that every 10 to 12 eggs equals 1 healthy baby. But because of my genetic mutation, half of those babies are going to be essentially BRCA positive. So take the number that you have and split it in half. So ultimately, the number that it came down to was, if you're lucky, you're going to get 1 healthy baby out of this extraction, which was like something that I was not expecting to hear. I thought it was going to be like a one and done situation. And this information I got last week. And so now I'm still like kind of, I mean, I'm going to do another cycle that I know. It's just a matter of when and how many times it's going to be. And I know that this is only the beginning of my journey of doing all of this screening for the BRCA mutation and being hyper aware of everything. And I know that when I do want to have children, that's going to be a whole other type of process, going through IVF and everything. But the way that I'm thinking about it is kind of just going one day at a time and taking it as I go, and feeling lucky that I have the information, feeling lucky that there's so much science that we can learn from and can take advantage of. And hopefully after me and after this generation of people who are BRCA positive, nobody's going to have to deal with it anymore. So that's the way that I'm thinking about it, and it makes it all worth it.
God willing, from your mouth to God's ears. I mean, I think that's the goal for all of this, that we can try to give our future generations, a better chance at all the things, at being
Yeah.
healthy, as opposed to what we have right now.
Yeah.
And science is an amazing thing when it works.
Mm-hmm.
Rachel, thank you so much. I'm going to ask you to, add in different pieces
Yeah.
as you hear Peggy and Dr. Wertheimer speak. But I think maybe, Dr. Wertheimer, I think maybe I'll come to you first, just because like the last piece that Rachel left us with was this, idea that, she thought that it was going to be one and done. She was going to do the egg freezing once, and then, that was going to be the answer to all of her issues. I think maybe if I could ask you to go and sort of explain, when you have a patient who comes to you and you're brought in as part of this, multidisciplinary team, as she was talking about, what do you say to them, and how do you outline for them what this looks like, what the process is, and how do you counsel people?
Yeah, so I do a lot of screening for BRCA and also all cancer genes in my initial consult, because if these people are coming anyways to freeze eggs, it's a good thing to understand like what kind of numbers do we need. And so you did a really good job about explaining the prophylactic mastectomy and the BSO. But so from a fertility perspective, we care about your BRCA status because of a couple things. There's some data that shows that BRCA mutation carriers actually have a lower ovarian reserve than other patients. So the whole prophylactic freezing your eggs is good for that reason too. It's weak data and not everybody does. And then the other thing is just that in general, just like you mentioned, the BRCA gene, because of its autosomal dominant nature, kind of cuts out, you think of half of your eggs as maybe carrying it, and not just half of your eggs carrying that, but at your age or whatever, there's also a certain percentage chance that some of your eggs are going to just be aneuploid and not going to give you a healthy pregnancy. So I like to describe it to my patients as a funnel, an IVF funnel, where you start off with the amount of eggs that we get. And, not every egg that you have on your ovaries is going to stimulate well and going to end up being a mature follicle. And then we go in for the surgery, and not every follicle will give you an egg. And then and not every egg will be mature. And then if you're just stopping at the egg freezing and not embryo freezing, we know that nationally the rates of thawing the eggs is about 80 to 85%. And so it's quite conceivable you can lose some eggs on the thaw. And then we have to fertilize them. So we usually think 70% fertilize, and then 50% make it to that embryo stage where we can biopsy them. And so then when you're at that point and you want to biopsy them, that's when what we spoke about comes into play, about having a euploid or a normal chromosomal number embryo, and also about the BRCA gene carrier status. And so it's not surprising to me that, although disheartening, that you would get maybe the chance of one live birth out of those eggs. And I actually tell all my patients, BRCA or not BRCA, that they're probably going to need to do egg freezing more than once. In an ideal situation, sometimes even more than that, but it's a cost benefit analysis.
Would you say, like, just to like actually make this like very clear for people, would you say, like, let's say you start out with 100 eggs that you're able to extract, so from 100, like, just break it down, like, just in terms of those numbers, like, what would you get at the end?
Yeah.
Oh, by the way, 100 is a totally
Yes.
unrealistic number.
Totally unrealistic. Let's say 20.
Okay, fine.
So I would say out of 20 eggs, let's say you have, 18 mature. Let's say, 16, 15 thaw. Let's say out of those, maybe 13 fertilize. And out of those, you're looking at maybe 6. And this is a great prognosis patient. Now that I'm thinking about my numbers that I've given, let's say we have 6 embryos, right? That's like really probably a young 20s patient. Out of 6 embryos, depending on the age of the patient. So let's say somebody's, in her young 30s, we're hoping the majority of those eggs are normal, right? So maybe 4 come back normal chromosomes. And out of those normal chromosomes, how many are BRCA? Maybe 50%. So let's say, how many did I say? 4, 2. Now we're down to 2 embryos. And we know it can take 2 to 3 embryos to get a normal baby per so each embryo has about a 60 to 70% chance of a pregnancy with transfer. So 2 embryos gives you a really good chance, and 3 embryos gives you about a 95% chance. So I would say, and a lot of our Orthodox Jews want a larger family size, I would say to definitely err on the side of caution and try to do this more than once. So sorry, how many eggs did you get? Oh, got it.
No, I was going to say,
I thought I missed it.
No.
I thought I missed it.
I didn't say.
Okay.
Not important. All good, all good, all
HIPAA.
good, all good. Okay, let me ask you actually another question. Rachel was saying that, from the time that she was diagnosed, and Peggy, we're coming to you very, very soon. From the time that she was diagnosed, that she actually found out that she was BRCA1 positive, and she was 21. She was told to wait until she was 25 before starting all of the prophylactic, like not prophylactic, but starting all of the different kinds of testing, the MRI and et cetera. And also my next question is, at what point, like, do you also say wait until 25 in order to do egg freezing? Like, would you say for someone who is, know that they have a genetic disorder, that they should start as early as possible? Like, what are your guidelines in terms of those pieces?
So in terms of the MRI and the screening, those are guidelines that were given by, I think it's the American College of Obstetrics and Gynecology, probably in tandem with some cancer organization. And I imagine that that's probably because the breast tissue is so dense when you're young, and also because the risk of cancer at that young age, even in BRCA1, which we know is the cancer that starts a little bit earlier, is still so low that putting patients through all that extra radiation and anxiety and everything is probably very not worth it. So the guidelines start at 25 and then get more kind of invasive as you get older. So that's for the breast screening. And then also the prophylactic BSO has to do with your cancer mutation.
Hold on. Tell me what BSO is. Just explain.
So the prophylactic bilateral salpingectomy and oophorectomy, which is the removing of the tubes in the ovaries, that what age that's recommended depends on the mutation and on childbearing and things like that. So, and the risk of cancer after a prophylactic surgery depends on what age. It's much lower, just like you mentioned, and it's very, very it's very reassuring to know that that's the data, and that's why I encourage everybody to, because there's an actual intervention that you can do that really decreases your risk. But the risk for ovarian cancer depends on what age you remove the ovaries. And then the last question you asked, the age of egg freezing. I don't know that we have a guideline on that. Like if a patient got really diagnosed really young, I don't know that I would tell a patient in her 20s, nope, come back when you're 25, because we know the younger you are, the more bang for your buck for an egg freeze. And so I think that it's worth a conversation with the doctor and going through kind of like that funnel and deciding.
And also, I mean, the one thing we're not talking about here is, at 21, people may still be in college. They may be in grad school. They may be starting their careers. Like it may be just impossible from a lifestyle perspective in order to like go through all of these invasive treatments. So I hear you. Yes. Like the answer always is, the earlier you do it, the better, but it may just not work for someone from all of the
Absolutely.
other perspectives.
Absolutely. Yeah.
Okay, one other question, and just to sort of needle down, just to make sure that people understand, like the ultimate treatment for BRCA1 or any of the BRCA. I am, this is not my area, so I just want to be very clear in terms of what I'm saying. But the ultimate treatment is to have your breast tissue removed and to have removal of your ovaries and of your uterus. But like specifically what you were saying before, you know, all of those things get weighed in terms of what you want your family to be. So it's all about like, do you want, if you still want kids, then you're keeping your ovaries and your uterus inside longer, but then that gets weighed against your increased risk of cancer. Is that right? Am I saying that correctly?
Yes and no. So first of all, you don't need to remove the uterus for prophylactic surgery. It's just the ovaries and the tubes. So that's kind of nice, because in that case, you can come back with these eggs that were frozen or these embryos that were frozen even after you've removed your ovaries, and we can still get you pregnant, which is a key piece of information. I wouldn't say the ultimate treatment is, but I would say the ultimate risk reduction is. So there's other things we can do, like birth control pills, tamoxifen, things like that. But ultimately, if you really want kind of like that anxiety-free feeling, then yes, it would be removing the breasts and the ovaries and the tubes. And you also, don't forget, have to weigh removing the tubes and the ovaries with the, now you're going to need to be on hormone replacement therapy, because you're young, you're not close to the age of menopause, and we need you to have estrogen for cardiovascular and bone health.
Correct. Yeah. Everything in life is about this balance, right? And
Exactly.
so very much here too.
Yeah.
Okay, I'm gonna put a pause on that. Rachel, is there anything you wanted to add to that before I come to Peggy?
No.
Okay.
Yeah.
Peggy, talk to us, number one, just about your role in Sharsheret and the kinds of education and resources that Sharsheret provides in general, but then also specifically what you do in terms of guiding people. You know, Rachel actually spoke to you years ago. I'm sure you speak to thousands of people. So the fact that you don't remember her means absolutely zero. But just talk to us a little bit about that and like at what point do people find you or what point do people find Sharsheret in this process?
So people come to Sharsheret at all different points in the process. And so sometimes I talk to people who are just trying to figure out, do I need to get a genetic test? Do I have to worry about what's going on in my family? And so we help people by going through their family history and trying to figure out if a genetic test makes sense for them or not. And people who need to think about having hereditary cancer testing are people who have a family history of cancer, but we want people to know as well that sometimes in small families or in families that predominate in men, sometimes there's not a lot of family history to see. So especially people with Ashkenazi Jewish ancestry, where mutations in BRCA1 and 2 are more common, we want people to think about having this testing done. Once you have this information, it's certainly, these are not easy decisions to make, but people can make choices that can save their lives. And so that's important to think about. Now, other people who call are more people who have already found out that they've tested positive. And so they're calling to say, well, maybe I never got a chance to speak to a genetic counselor and I'm not really sure what comes next. And I'm worried about the details and nobody has really explained it to me. And I can help people and go through what all the issues are and what the national guidelines say. Now, I'm not a physician, I'm a genetic counselor, and so I'm very careful, as everyone at Sharsheret, we don't give medical advice. So I'm not going to tell you, you should have your ovary taken out as soon as possible. That's not my call. But what I'm going to explain to you is, given the mutation you have, what do the national guidelines suggest you should do? And I think it makes it possible for me to really help people because they know I'm never going to come at them with anything bossy or unwelcome advice or trying to tell you, you really need to have surgery. You really need to have surgery. I never say that. I always say, you have lots of options. Here's what the options are, and here's what might happen. And let's talk through and think about what's the right choice for you, because everybody is different. And some people want to have that surgery right away. Other people are not ready. And, the same thing in terms of using IVF and PGT, which is the embryo screening. That's not something everybody wants to do. And again, we don't tell people that's what they need to do or should do. Everything is a choice. And I'm going to just help people figure out what feels right to them.
How do you advise people who are getting, like, you were saying a little bit about, the parents or the friends or whoever knows, and people are coming in with these ideas, this advice, oh, you should, the shoulds. How do you advise people who are dealing with the constant shoulds in their life where they know that that's just not right for them for whatever reason, because there are a million reasons why someone would not choose to go through surgery and have all of these things taken out. There are also a million reasons why people would choose why not to specifically select out for embryos, or why people would choose not to freeze their eggs. So how do you suggest that people deal with the constant chattering that goes on?
Well, I think that people have to understand that this belongs to them. And I think it's part of why sometimes people want to keep this more private. And when I talk to parents, especially older parents, parents of adult children, I remind them that our adult children are no longer need to be told what to do, and it is up to them. And very, very important, when you tell your children about a mutation that may be in the family, you're going to tell your children that you've tested positive. You're going to tell them what choices you made. And in Rachel's situation, she saw the choices that her mother made. But the most important thing as a parent then is to say, you know, you're going to make the decisions that are right for you, and to take a little bit of a step back. Now, it's a doctor's job, of course, to give medical advice. That's why they earn the big bucks. So when people want advice at Sharsheret, we suggest to them, talk to your doctor and see what they think is going to make the most sense for you. But good friends know, and good parents know, that they should not be nagging at their children, as hard as it can be as a parent to not tell your kids what you think is the right thing for them to do. It's smarter to let people figure out what is the right choice. And speaking with someone like myself or another genetic counselor who's doesn't really have skin in the game, can help to just clarify what are the facts and how do I make this decision. And I can help walk people through all of those steps.
Yeah, I loved hearing what a team you had to support you. That's really nice.
Yeah.
It is incredible, absolutely incredible. Let me actually like flip the question a little bit, both to the two of you, Dr. Wertheimer and Peggy. And you know, Rachel's story is very specific in that, you know, she knew she had a diagnosis. She decided to do something about it. She went down the egg freezing route. Different people, you know, in her family chose different things or didn't, and that was her story.
Mm-hmm.
But now let's take someone else with a different kind of story,
Mm-hmm.
someone who has a known cancer diagnosis already. And then what? Can you talk to us? So maybe Dr. Wertheimer, I'm going to come to you first. Talk to us about someone who has a known cancer diagnosis, and are not finished in terms of their fertility years. They thought, they hoped, they wanted to have more children. How do you counsel somebody? How does that even work? And then Peggy, I'm going to come back to you and say, like, what do you say to someone also at that point? Because they're, you know, the emotions of like, well, what does this mean? And does chemo, and I sort of, these are questions actually really for both of you, you know, is chemo or radiation going to kill my chances? Do I have to freeze beforehand? When am I allowed to try again? I mean, and I know that these are very broad questions. It's impossible to answer. Like, every person's situation is very different. But if you could both sort of give us an understanding of what that kind of patient would deal with in terms of this kind of situation.
A known cancer diagnosis, not a cancer gene.
Correct.
Okay, so the cancer patients that come in with a known diagnosis, it really depends what kind of cancer and how urgently they need treatment. So we do a really good job, and I would say this is probably across the board, all fertility clinics kind of take these patients in as soon as possible through the wait lists and whatever, because of the urgency of the matter. But ultimately what we want to know as the doctor is, what is your oncologist recommending? Is it surgery first? Is it radiation first? Is it chemo first? And how much time do we have? Because even so, from a fertility standpoint, we can do an egg freeze as a random start. We don't necessarily have to wait till a period or birth control or whatever, but we need, you know, like 2 weeks to get to the retrieval. So if we don't have 2 weeks of time, there's unfortunately not much we can do. There's more experimental therapies where we can do surgeries to try and remove the tissue and freeze it, but those centers that are doing it are few and far between, and sometimes it's like not even in the same state. And then just
And
in
you're
terms of
talking
that,
about, and just to be clear, you're talking about removing ovarian tissue to
yeah,
actually, okay.
yeah, to remove ovarian tissue and freeze it with the hopes of maybe being able to reimplant it in the future, or to extract eggs from it and you know, do something with those eggs. And that's very experimental therapy. In terms of like that patient's overall, like if they're just asking me, you know, what is my chance for fertility? Again, it matters what type of cancer and what type of chemo or where the radiation they're going to get is. So there's different levels of gonadal toxicity that means the like toxic nature of the medication to the ovaries, and that depends on which chemo. There's ones with lower toxicity where we know patients have had this chemo and they've have a resumption of menses when they're done with chemo and they've been able to get pregnant, you know, and with a healthy baby. And then there's people with medium and intermediate risk and people with high risk. So it depends what the nature of the chemotherapy is. But I think we would all agree that if you have the time to freeze the eggs, even if you're using a low gonadal toxicity, it's probably a good idea to do it, just because ultimately you don't know how much it's going to affect your reserve. And then for radiation therapy, if it's directed at the pelvis, it's, you know, it could be pretty toxic. It matters how many gray of radiation, like what the power of the radiation is. And there are things that you could do to try and mitigate the risk, like if depending where the radiation is going, trying to shield the ovaries, or trying to, sometimes there's discussions of transposing the ovaries, like doing a minor laparoscopic surgery to move the ovaries up in the pelvis so that they will get less radiation. But all of this depends on time and all of it's experimental. There's also an injection that we give that we think might shut down the hormonal axis, and there's not great data behind that either, but we kind of feel like, okay, why not just do it? I don't know.
Try something.
Yeah,
Try something.
even the letrozole that you had mentioned, which is the medication that you were saying, the name of the medication that you were saying to try and decrease the estrogen in your body as you're going through the treatment therapy. We'll do that with our cancer patients as well to try and keep their estrogen levels low, but all of that's also experimental, and there's really nothing to prove that that helps, and definitely not in BRCA mutations. We kind of just do it because low risk.
Yeah. I just, before I come to you, Peggy, Rachel, you clearly have a fan club here because your mom and other people are all like commenting in here, like how amazing the support
So
system you had
sweet. I
were.
love
And
that.
I mean, amazing. And how you were really only dealing with, we are not talking about you here. We are talking about someone in this specific scenario. You were dealing with a prophylactic, sorry, not, prophylactic process where you knew you had the gene, but you absolutely did not have cancer. We're now in the a different scenario, just in case someone comes. So I just want to make that clear for someone who's coming on right now. Peggy, your thoughts about that piece?
So we've had a number of Sharsheret callers who've struggled with this issue of deciding after a diagnosis. And I know it is important to try to do something at the very beginning to try to improve chances. We have had callers who chose not to go ahead and have eggs retrieved and were able to get pregnant even after chemotherapy. But I think it's more difficult in that situation. And so there's a lot of when someone gets diagnosed, I'm thinking of a particular caller that I spoke to who was diagnosed while she was pregnant and found out she was BRCA positive and still wanted to have another child. There were a lot of things to think about in a very, very short period of time. And for many of these women, it can be helpful just to have somebody to turn to who's not the one who's giving them the advice, but who's listening to them and can help them talk through all of this and make what's going to be the best decision given all of the people involved and all of the circumstances. And Sharsheret, between myself and the team I work with, who are amazing social workers, we can really help people from a psychosocial point of view really approach this and figure out what makes the most sense. But we've had many women go on and have children after cancer successfully in many different ways, sometimes with reproductive assistance and sometimes not needing that. So there are lots of possibilities. It depends on lots of other factors.
Okay, perfect. Okay, as we're wrapping up here, what I would say, Rachel, I'm going to come back to you. Thoughts, like for the person out there who has gotten this diagnosis, or maybe even the person out there who is thinking about whether they should get tested, whether they shouldn't get tested. Like, if you had to do it all over again, would you do it? What is your advice to people out there who are potentially grappling with this?
Yeah, so I would do everything that I did again in a heartbeat. And I definitely wouldn't change anything that I've done so far. I think partly because I don't know any other way. Today, actually, I was talking to my mom on the phone, and she's like, "Do you even know anybody of your age who's been tested for BRCA or BRCA, whatever?" And I have no idea. And there must be people out there in our community that are BRCA positive or who have a history of like a family history of breast cancer, um, and maybe thinking like ignorance is bliss. I think that's true a lot of the time, but right with something like this, especially because I work in oncology, you can see there's so much that's out of control when it comes to cancer diagnosis, increased genetic risk. But when you have the opportunity to take control of the little things, I would do everything you can in your power. Whatever decisions that is for you, but at least getting the genetic testing to at least know and then make your decisions from there. That would be my advice. And then trying to find a support system of people that will support you no matter what, and who will make you laugh through the process and kind of I think that's the most important. So that's what I would say.
Amazing. Dr.
Uh,
Wertheimer, oh, sorry, Peggy, go ahead. You want to say something?
Yeah, I would just point out that one of the things that we offer at Sharsheret is peer support. So if someone wants to talk to somebody who's had an egg retrieval to know what it's like, or if someone wants to talk to someone who used IVF and PGT to have children without a BRCA mutation, those are all peer supporters that we have, and we can set you up to talk with somebody who's been through it. And that's true for the prophylactic surgeries, or for being young with BRCA, for being older with BRCA, all of these. We have lots of people who are ready and willing and able to talk about these situations. And I'm a genetic counselor. I know a lot, but this is not my personal story. And so that piece I can't do. And that's what we rely on our volunteers to do that part.
Amazing. Sharsheret is an incredible organization. So I'm going to ask the same question to you. Advice that you would give to people out there, people who may know, may not know, what what would you say to them if there's a person lingering out there who, whatever you think, whatever you personally think, and we were talking about this earlier, like, I think we in the medical field, and all of us are in the medical field, actually, we often think like, get in, get tested, like knowledge is power. You want to know now, you want to do this now. That's not necessarily right for everyone. Like, how would you advise someone who's potentially sitting out there with a maybe something?
You're asking me, right?
Yes.
So, yeah, so I always tell people, I never say you must get tested, but I always say these are the advantages of getting tested. And I think the advantages outweigh the disadvantages for most people. You really have the opportunity by getting this testing done to perhaps avoid a terrible cancer. And I think maybe as healthcare professionals, we see more what terrible cancer looks like, and we don't want that for anybody. And if it can be avoided, that's a beautiful thing. But at the same time, not everybody wants to do this. And so when I talk to my callers, it's always with a gentle voice to say, these are the advantages, these are the disadvantages. It can be hard to know this information about yourself. It is hard to know, but by not finding out about it, you can't prevent it from being there. So you have to think about all of those issues and figure out what makes the most sense for you.
Perfect. It's amazing. Thank you. And Dr. Wertheimer, I'm going to give you the last word. Thoughts about all this to close us out?
Um, no, I think everybody said everything beautifully. I think that there is a lot of fear in getting tested, and I totally understand that. There's some diseases where you get genetically tested and there's really not anything you can do except sit with your anxiety until that disease hits. This is a mutation where there is an intervention that can make a really big difference for you. And when you say knowledge is power and that might not be the right thing for everyone, I agree. I think that getting the mutation tested might not be something that someone chooses to do, but I would at least go in for a consult with a genetic counselor or an REI and just hear out what the range of possibilities is, because then it might not be so scary. And I think part of what's so scary is that people don't even know that those are things that they can do, which is why this is such a great Instagram Live. And thank you for spreading awareness, all of you.
Thank you. Thank you all. Look, it's exactly the reason why we do this. We are a fertility organization, but the point of having these kinds of discussions are because this directly affects people's fertility and it affects people's lives. And this deeply affects people's psyches, the choices of should we test, shouldn't we
Right.
test? Should I do the prophylactic surgery? Should I not?
Right.
Should I go through the egg freezing now? Should I go through it later? There are a million pieces of this. And I'm just going to end with, there are times where there isn't that option. We just posted, we had a post earlier today with a woman who got a very aggressive diagnosis, and she was unable to have any of these choices. She had to go straight into treatment. And that treatment meant removal of the possibility because she had these surgeries, and she had to get rid of it because she had to get rid of her cancers, removal of the possibilities of her being able to further her family. And for many people, that doesn't have to be that way. And technology exists now. Again, you can choose to do with it what you want, but that's exactly why we have these conversations, to spread awareness and sensitivity. So thank you, all of you, for being here. I'm deeply indebted to you, and the community is indebted to you. If
And
any
to
of you,
you, Aimee, you're doing great things.
no, if any of you want to reach out to any of the people who are here, and for whatever reason you don't grab their handle, you can always reach out to us by DM or by email, and we will connect you with any of our speakers. Good night, everybody.
Good
Thank you
night. Thank
again.
you for
Thank you.
having
Thank
me.
you.
Bye.
Bye.
Bye.